Sidramon, are you maintaining the class? Yes. You have it. Yes. If I ask you what day we do what class. I mean, I have it in my YouTube as well, but sometimes I might even forget to take the video that day. Can you just do the same thing for me once again? I don't think that many classes were taken.
We keep an index.
Yeah, keep an index. All of you keep an index, so that you can actually correct each other. Were we studying Optic Nueritis from Wilside or Khurana? Did we at some point open Khurana as well? Yes. And did we start from Khurana? And did we complete Wilside? Okay. So, you could give me a number. Dinner? Assignment? Forgot? Marcio. If you marane, then you Marcio. Did you want?
Age of onset of multiple sclerosis optic neuritis.
22? 40. Namaka, others in the net out in the why did I?
It is second and third decade of
What age labor hereditary happens?
that is second and third decade of life. That is 20 to 29.
Not with. Is that what you're telling me?
Yes.
No, that is
What are you telling me?
age of onset of multiple sclerosis optic neuritis.
Why did I ask this one? Because we are having old patients, 65 plus age in the patient's age.
So we
Was that the topic?
MS etiology.
Maybe we were discussing GCA, and under GCA, old people were getting MS. So I think I had asked her to find out what were the process. Okay, fine. Anli, what was your level?
White matter lesions.
Yeah, please. Most difficult is there. Did I give you an assignment? Okay, find it in 1 second. White matter lesions, right. There is a very crazy website called radiology.net. Radiopedia. It's surprisingly difficult to find. This. Girls. What is this? Please. What is this?
Optic
What is this? What is this?
Or
Huh? Then also. Then the lateral is in the superior or inferior. Superior. Then the then the black color line. The black line. Superior ophthalmic vein. Then the what is this small cute structure? Huh? This is lens. How come there is no white layers? It's impossible. Sorry? I'm not sure. I don't want to say yes or no because there are so many common things. I want to show you such a simple image, but after that you will never ever forget it. Surprisingly, I'm not able to find it. A 46-year-old man with secondary progressive MS, which is hyperintense with T2 weighted. So this circle, can you see? That is, which is hyperintense with T2 weighted image, and hypointense. This is black, right? With T1 weighted image, also called as a black hole. That is not so convincing. We'll see one more. A magnetic resonance imaging of a 30-year-old man with relapsing and remitting multiple sclerosis. Plus, what am
one question I did sir from find out the
already which? Child is undergone muscle surgery in his right eye for deviation of surgery in his right eye for deviation of 35 diopters for this one. The patient had experienced double since the operation. The present model is using the residual obstructive in the abdomen and sensitization in the uncrossed the offer image patient background differences to be an outlet correspondence. The appropriate disadvantage with that. So what is this?
Find out what are the anomalies you can see in this case.
Anomaly. What does it mean by anomalies? Because it's a case. I mean, what anomalies do you expect? If it's a 30-year-old man who's having exotropes on childhood, he should not have any vision in one of the eyes. One eye should be dominant and one eye should have suppression. Now, he had undergone muscle surgery in the right eye for a deviation of 35 diopters before we saw him. So he already had a different 35 diopter, that means it was around 17 degrees of deviation, probably more. The patient had experienced double vision since the operation. He should not have experienced double vision because one eye should already have been amblyopic. How is experienced double vision? The vision covered has received an isotropy of 10 diopters at Neuritis. The patient had uncrossed diplopia. Probably it's crossed diplopia. But he's misleading. I don't know if it's a case where they are misleading you and they are supposed to find false things, or whether it's a correct case and they are asking you how to manage the motivations. I don't know what the question is here. It's unclear. So, MRI of a 30-year-old man with relapsing and remitting multiple sclerosis. Is it a good thing? Relapsing and remitting. When money gets remitted into your account, it's a very good thing. So, relapsing and remitting multiple sclerosis, is it a good thing? When money has come back into your account, it's called remittance. So, multiple sclerosis also coming back and again, it's a bad thing. So, relapsing and remitting is a bad thing. I had he was a girl who we had a friend who had cancer. So not a friend, he was a relative. So we told that cancer has relapsed. She started saying congratulations with hearts and everything like that. So that word is misleading to some people. A T2 weighted image, rotor density useless, fluid retention useless. It's not been described. For now, the takeaway can be, look at this white thing. This is ventricular, this is ventricles. Ventricles are pretty space in the brain, which the cerebrospinal fluid is moving around. Around the ventricle, which is this periventricular area, you have whitish lesions, which is what white matter lesions we were actually expecting to find. And then the same thing when it was done on T1 weighted, we had black. Which is which? Which is T1, which is T2?
P2 is
It is whitish. Okay, tell me which is T2. It is black.
the vision of
Region of it is white. So if it was a healthy guy, would you be able to tell? Which is T1, which is T2? Imagine this is not there. This lesion is not there. Okay? Can you tell? Which is T1, which is T2? See, the simple thing is, you don't see in the lesion, you don't see in the brain's color. You see in the water inside the brain. Where is the water inside the brain? It's at the ventricles. That ventricle is there. This part, the Batman logo. That is ventricles. So inside the ventricles there is CSF, like I told you. TWO, T2. W is white. That fluid will be white in T2. Okay. Where is the fluid white?
second one.
The first one. Fluid is white in the first one. The brain is white in the second one. So looking at the white brain, the T2 looks like that is T2. That's not T2. The fluid is what we judge it with. So the fluid is white in the first one, so that is T2W. W for white. T2 weighted is the first one. T1 weighted is the next one. Now, is it a flare sequence or a stir sequence? It's a flare sequence. Why? Multiple sclerosis and optic neuritis, we have always flare sequence, flare MRI. Flare T2 and T1 MRI. Whereas stir MRI is used where?
Third diagnosis. Last class include.
Thyroid disease. I didn't say third number. Thyroid disease. Third number. Third number നമുക്ക് എന്താണ് പേടി MRI. Third number നമുക്ക് എന്തെങ്കിലും പേടി ഉണ്ടാവും. Pupil constriction.
Dilations.
Pupil dilation is there, should be worried. What are you looking in MRI? You don't know, third term disease is MRI stir. MRI for stir is thyroid. Whereas in third nerve disease, third nerve palsy, damaging disease, third nerve palsy, in the MRI you are trying to see the aneurysm. Okay? You are afraid of aneurysm. Flare Optic Nueritis MS. Look at this. This is better. Are you able to see Fatima?
No.
I will show you. Look at the state of my table. Never has it been so dirty. It's lovely. Nicely, patients are walking. So, look at this. Can you see this? Can you see this? So nice. Okay, this is better, right? Can you see this white color, Fatima?
Yes.
Okay. Can everybody see? The same thing is being shown as black color. Maybe it is important in MRI. Like everywhere they are showing white and they are showing black as well. So which is T1, which is T2? Okay. T2W for white. White is here. Now white is here as well. Should white be here? No, white should not be there. Okay. This is what MS means. Now let's look at this. Top row. A hyper intense lesion close to the cortex. Where is the cortex? This is the cortex, or this is the medulla? This is cortex. This is medulla. Medulla is a substance. Cortex is the cortex. Can we remember it by some way? Cortex. You've never heard the cortex. Cortex is very common word. Medulla, medulla. Okay. Cortex is here. Okay. So that this is the cortex. Median close to the cortex. It is white arrow. Which is visible or not? Yeah, forget that. Middle row. A hyper intense lesion close to the cortex. Again, one more hyper intense lesion. Is visible on DAR, shows that the lesion abuts the cortex. Bottom row. A hyper intense lesion close to the cortex is visible on DIR, so the lesion is intracortical. Under the proposed system, the lesions in the middle and bottom rows will be classified as cortical and extracortical. So, not going too deep into anything. This isolated lesions are, for some reason, more important. There is something, this white, okay? To make it very extremely simple. I would actually go one step further and say, this is ventricle, this is ventricle. This stuff, this periventricular white color regions are also what could be leading to multiple sclerosis. I know I'm wasting some time, but if you see it once, you'll never forget it. And if you keep on reading white matter lesions in MS, you will never really get it. So, this is how they look inside the brain. Okay, there are these holes, hollow holes are there. Right? We can understand, right? This part are getting thickened. The erosis is happening. This was the American guy who was staying in my thing. Left me a nice. So, where were we? This is Optic Nueritis. Is anything remaining in this side? Treatment. Oh yeah, IBMP. We skipped that on purpose. Let's finish it and call it. Did we do anything in workup? For all cases, MRI of the brain and orbits with gadolinium and fat suppression is important. In that, you might see a white lesion. MRI of optic neuritis showing an enhancement of the right optic nerve. Shit, we didn't see that. We didn't see optic neuritis. Okay, there is enhancement of optic nerve. Which is this? Is it the right optic nerve or the left optic nerve? First. Left.
Left.
It's the right.
So the patient is lying like
It's the right.
right.
How is it possible?
That's right.
അല്ല എനിക്കിത് പറഞ്ഞാൽ MRI top to bottom പോവോ bottom to top പോവോ ആയിരിക്കും top to bottom ഉള്ളിലേക്ക് കയറും അപ്പോൾ ഓൾറെഡി മഷീൻ അവിടെ റെഡി ഉണ്ടാവില്ല ഉള്ളിലുണ്ടാവും so if it is going from top to bottom this slice is going top to bottom so you are seeing the patient's head from the top അപ്പോൾ
That's
the
right.
left arm why is this thing right it's so strange അല്ലെങ്കിൽ
പക്ഷേ patient തല അവിടെ ഇല്ല. അവിടെ ഇല്ല. അങ്ങനെയല്ലേ. It's written right.
It's written right.
it's written right we are not guessing we are trying to figure out why it is right because our understanding has always been that it will go from up and down
It's right.
see it's very simple if you are arguing that it is right as he is saying then you are saying that we are seeing the patient from the bottom okay if what I and Anil are arguing is the MRI is normally shown from the top to bottom. That is how the MRI goes. So we are seeing the patient from the top. If I am correct, then that is left. If you are seeing from the top. If you are correct, then that means we are seeing the patient from the bottom. The takeaway thing from here is from now onwards, you should never think that MRI is taken from the top. Rather, you should actually think it's taken from the bottom. Okay, that means the legs are here, abdomen, hands, face, that is the left, that is the right. Okay, if you imagine this video like this, then you will automatically say which is the right hand. There is this one. So MRI, where are we looking at the patient from? Bottom. CT, also bottom, because MRI and CT are the same, as in the agitation. So this is bottom, that also has to be bottom. So next time we come across an MRI, we'll again correlate with the theory to it. Okay, so complete ophthalmic and neurologic examinations. Nuclear examination is very important. Color vision is very important. Dilated retinal examination, even though it can be completely normal. Why? Why can it be completely normal? Why can dilated retinal examination be normal? Because it's not necessary that you will have optic neuritis. It might be retrobulbar optic neuritis, where there is no disc, where there might not be papillars or disc edema might not be there. If you have a disc edema along with macular involvement, that is called neuroretinitis. Or only disc edema is there and no terminal papillaritis, it will be the later stage. Or only retrobulbar optic neuritis. Okay? Is the staging given in optic neuritis? Not given staging? Was staging given in? No, never it was. That is why I wanted to study Prana also for this topic. Prana it will be given much more in a nice one manner. So you are supposed to do visual field test. You're supposed to do FT-ABS for syphilis, Lyme titer for Lyme disease, ESR for GCA, chest X-ray for sarcoidosis, CBC to look at white blood cells and inflammation is increased or not. RPR is also for syphilis. So every test has a reason. It's not there or test is illa. Uh, just like you guys might remember, I told you let's spend one door open up. Yeah, it's open. Correct time you're closing. Just like you remember, guys, remember I told you Rani means you have Rani which you have like point 3,
Five.
point 3. Point 5 is Odulex. Point 7 is Triamcinolones. Point 3 to point 5. But I told you remember it as point 3. Then point 5 is Odulex. Then point 7 to 1 mg was. Am I wrong? I'm wrong. Point 5, point 7 and 1 mg. So point 5 mg, that this is the kind of thing I wanted you guys to have. I wanted you guys to correct me. This is the level I wanted you guys to have. For that reason, once I will come across something which is always repeating. This is the thing. Second thing is IVMP, that dosage. Every inflammatory disease, I always use the same dosage for IVMP. Third, IVMP is not yet there. We already completed IVMP in thyroid disease as well, but I'll be doing it again today. So that way we have good revision. Third thing that we always keep on repeating is this CBC, RPR, FTABS, Lyme titer, ESR, chest X-ray. Why do we do chest X-ray? Sarcoidosis. Why do we do ESR? GCA. Why do we do Lyme titer to find Lyme disease? Why do we do FTA, ABS and RPR to find syphilis? Why do we do CBC to find the increased white blood cells in the body? Okay? ഇത് മാറി ഇങ്ങനെ തന്നെ നമ്മൾ പഠിക്കുമ്പോൾ വളരെ ഈസി ആയിട്ട് പഠിക്കാൻ പറ്റും. So one day you come across this, you feel this is too complicated. How does anybody remember this? But if you do it again and again, it's actually quite simple. ESR for GCA. RPR is also for syphilis. Rapid plasma reagent test. CBC is for increased inflammation. That is autoimmune diseases. Might have white blood cells increased. So okay. Treatment. If patient is seen acutely with no prior history of MS or optic neuritis. So there are two types of treatments. If patient had no prior history of MS or optic neuritis, and the second is if patient is a diagnosed MS, how to treat it? They are both different. So can somebody read this? Or should I repeat this? Repeat it. Nice, healthy girl is coming to you, which is an optic neuritis. What are you afraid of?
MS.
You are afraid that today she is beautiful and healthy and nice, but within 5 years she'll become Vidya Balan in the future. That is what you are afraid of. That picture you are afraid of. So to counteract that, to first save the vision, this is what you are giving. If MRI reveals at least, then you do an MRI first, obviously. If MRI reveals at least one typical area of demyelination, offer pulsed intravenous steroid therapy. Pulse therapy. Okay? Pulsed intravenous steroid. Which intravenous steroid will you give? Methamphetamine. In the following regimen, within 15 days of decreased vision, within 15 days, within 2 weeks, vision has decreased, you are supposed to give this. How much will you give?
1 gram.
1 gram per day, for 3 days. This actually changes sometimes. Sometimes it becomes 1 gram per kg per day. That is only so 1 mg per kg per day, I think so. Yeah. It is 1 mg per kg per day. That means maximum it might be 100 mg. It might not be 100 mg. For 3 days. But here is telling you 1000 grams per day. 1000 milligrams per day. It's very different. It's 10 times more stronger in this thing. So right now he's telling us methylprednisolone 1000 grams per day for 3 days. Then orally prednisolone when it is given, you're supposed to give prednisolone 1 mg per kg per day for 11 days. 1 gram is given for 3 days.
Sir, in Rana
Rana
also
also
the
says the
same.
same thing.
1 gram.
Yeah, 1 gram.
Yeah, no, I'm not actually saying this is wrong. That could not be possible. What I'm saying is, what I'm normally used to is 1 mg per kg per day is what for the number. That is per oral. Whereas IV is giving much higher dose. Probably since it's the earlier dose and IV dose has to be strong, he's giving very high dose. Jina, are you with us today? Very quiet. Eyes are becoming dry. Do we have any different tears?
Yes.
Yeah. Can you just put 2 drops in your eyes and just close your eyes for 10-20 seconds?
She's not.
So, prednisone 1 mg per kg per day for oral. Maybe we can remember it like this. Oral drugs are supposed to be given less. Why? Because when they go to the stomach, they might cause too much GIT, acidity issues. But IV, they will not cause any acidity issues. So you can give a lot of dose in IV, and IV is given initial loading dose. Then maintenance dose is prednisolone. So maintenance dose to this to is given low. You remember it like oral is given low, IV is given high for 11 days. Then taper prednisolone. After she has used never seen 4 days. Just close your eyes for 10 seconds. Don't look at any screen and relax. Then you can open your eyes. Taper prednisone for 4 days. 20 mg on day 1, 10 mg on days 2 and 4. I can never figure this out. You guys have a thought for this? Girls will be able to. Huh? For what? No. See, I'll tell you why it's not that difficult for me in this part. IVMP. Wherever you say IV, always MP at the end. IV ఉన్నది prednisone ఉన్నది మిథైల్ prednisone. IV. Okay? ఆ పాట మీకు కన్ఫ్యూజన్ ಇಲ್ಲ. And IV, since it is IV, it has to be MP, it has to be high dose, 1 gram. That is 1000 grams. That I'm okay with. Okay, I will clear now. ಅದು ಇಂಟ್ರಾವೆನಸ್ ಇರಲಿಲ್ಲ ಇಂಟ್ರಾವಿಟ್ರಲ್ ಅಲ್ಲ if it is intravenous it is MP like you put it like that intravenous MP IV IVTS intravitreal will TA ഉണ്ടാവും that's okay പക്ഷേ intravenous ഉണ്ടെങ്കിൽ MP ആണ് അതുപോലെ തന്നെ കഴിക്കുമ്പോൾ ടാബ്ലറ്റ് ആണ് റെഡ് എസിറ്റേറ്റ് ഡ്രോപ്സ് ആണ് റെഡ് എസിറ്റേറ്റ് ഡ്രിങ്ക് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ സിറ്റുവേഷൻ്റെ റെഡ് എസിറ്റേറ്റ് എസിറ്റേറ്റ് ഫോമിൽ നമുക്ക് കഴിക്കാൻ പറ്റും ബോട്ടിൽ യൂസ് ചെയ്യാൻ ഓക്കെ രക്തങ്ങളുടെ ഉള്ളിൽ ചേരുന്നെങ്കിൽ മിഥൈൽ prednisone ആവശ്യമുണ്ട് മിഥൈൽ ഗ്രൂപ്പ് അതിൻ്റെ ആവശ്യമുണ്ട് ഓക്കെ I know it's slightly confusing but this is the most repeating thing available. First time you might find it confusing but very simply just like this tests you will find it far more this it's simpler later. Then what else? So prednisone is 1 mg per kg per day. So when it's oral, it is prednisone. That is what I'm confused about. What I'm confused about is how to taper them. First, it is 1 mg per kg per day, which is how much mg? In 1000 kg. 5 kg. Huh?
50 kg.
So approximately 70 kg. So if I ask how much prednisone will be given to Dina or to you, then I can know your weight. Basically, that is how 1 kg per mg per day. Now, I normally take it as either 100 mg or 70 mg. 70 is most of us are 70 mg. I don't know about you guys. One is 70 mg. 70 mg per kg per day for 11 days. Now the confusion starts for me is how to taper it. From 70 kg he is saying, then for 4 days give it 20 mg. No. He's not saying. He's saying, now after you have given 11 days, 70 mg, 70 mg, 70 mg, 70 mg, 70 mg, 70 mg, then you start on, after 11 days are finished, then in the next 4 days you are supposed to taper immediately. First day, 20. Second day, 10. Third day, 10. Fourth day, 10. After 5 optional. Maybe not even. So that's not that complicated. So first 11 days you have 7, 70, 70, 70. Then you have 20, then 10, 10, 10. Tapering is done. So now we have a good 20, 10, 10, 10. It's how you are supposed to taper in 4 days. And I'm always supposed to give anti-ulcer medications. Why? So acidity will increase. That is why they are giving less prednisone and acetate when it is supposed to be eaten. If MRI shows, till now we are treating healthy girl. Fatima?
Yes.
We are treating healthy girl is connected with 2 eyes of You are okay, Dina? Better? One more drop you want?
No.
One typical area of demyelination. MRI is having no prior history of MS or optic neuritis. So, no prior history of MS or optic neuritis. First time optic neuritis is coming to you, then you do the MRI. Immediately you find there is white lesion, only one white lesion is there. Immediately you start with prednisone 1000 grams per day. I'm seriously doubtful about this 1000 grams per day. It is only for MS or optic neuritis, is my suspicion. Remember this point, next time when we are studying IVF or anything like that, it will not be so high. Or perhaps if it is so high, then you can remember this is the same thing that is repeating everywhere. Then prednisone is 1 mg per kg per day oral. So can anybody tell me from start? IVMP you are giving 1 gram per day
for
3
3
days. Then you are giving oral
Oral
penicillin
1 gram to 1
kg.
or can you make it simple and called 70 milligrams?
70
70 milligrams for 11 days. Then 20.
20.
Then
10,
10, 4 days taper. Finish. And also give anti-ulcer medications. Optic Neuritis treatment trial (ONTT) found steroid treatment reduced initial progression to clinically definite multiple sclerosis. So initially giving IVMP is very nice. Because who told you this? ONTT told us this. Should I trouble you guys and ask you about all the other trials we saw in CR Bravo and Cruz? No, we'll do a revision study once, okay? Actually, at the end of every month, we are supposed to do the revision classes. So, ONTT told us that initial steroid treatment reduced initial progression to clinically definitive multiple sclerosis. So, she had multiple sclerosis sign, but if you gave her IVMP, she was very safe later on. So, is giving steroid nice or bad? Sleepy girls.
So ONTT, they have done 3 studies. So one is IV, then oral steroid, and oral steroid alone,
Where is it
and
now?
on
Maybe studied this.
not in the Corona.
Maybe studied in the other book.
Yeah, in that.
Did I tell you that?
Yeah,
Tell me the
so
summary.
they have done three things. One is IV, then IV with steroid, only steroid and phase one.
Yeah, and whatever.
So IV with oral steroid is the best.
Good. So IV with oral steroid is the best thing, and they are actually very very good. So we spending this much time on finding out what to do if it's a healthy girl with one multiple sclerosis lesion, and spending some time looking at the MRI and learning how the MRI looks in a healthy girl with MS, probably MS, and also what drug to be given to these people, even if one lesion is safe, is not useless. We are actually saving somebody's future from becoming bigger. So steroid therapy only increases the rapidity of visual return but does not improve the final visual outcome. Oh, this is a super point. Steroid therapy increases the rapidity of visual return, does not improve final visual outcome. Visual acuity is not improved. Visual acuity is not improved. So strange. But what has been blurred will come back to nice point, but visual acuity will not be very. It will not go back to 6.6. But if it is 6.60, then it will come back to 6.12 very easily. There will be rapid recovery, but will not completely recover to completely perfect. Okay, this thing is supposed to be told to the patient, so otherwise the patient will have a high expectation from us. What else is there? If MRI shows two or more characteristic demyelinating lesions. Okay, this was till now, it was for only one lesion. Now let's look at what will happen if it's two. If MRI shows two or more characteristic demyelinating lesions, treat with the aforementioned steroid regimen. Refer to neurologist or neuro-ophthalmologist for possible treatment with interferon beta 1 gamma, galatrimer acetate, with fingolimod within 28 days. Patients with one typical signal changes on MRI have a 72 chance of developing CDMs over the years. So basically, you are fighting with three things. You are fighting with three lesions. Okay. First lesion, you are giving IVMP. Then you are giving prednisolone. Then you are taking the dose. You are ready to go. Two lesions, you are also giving IVMP. You are also giving prednisolone. You are also giving tapering. And you are ready to go. But also this time you are also saying the because the neurochromatist as well. Then you will give fingolimod 28 days. There is a big drama. If there are three lesions, the moment she has three lesions, then she has a 72% chance of getting MS within 15 minutes. Okay? So, what to do if there is only one lesion? Are you supposed to wait for 2 lesions to come? No.
IVMP.
So, it is on a table. What to do if there are two lesions?
IVMP.
And Ophthalmology. Never ever wait for 3 lesions to come. Okay? So, these two places also you can, this is what initial OLT tells us. Initially, saving it as clinically definite multiple sclerosis can be stopped. With a negative MRI, two or more demyelinating lesions, treat and refer to neurologist. And you give fingolimod within 28 days and interferon. What about girls? Clinically definite multiple sclerosis. Because right now it is, we are giving initial treatment with steroid. It is only multiple sclerosis suspicion. Before it becomes 3 lesions, then it is clinically definite multiple sclerosis. Now, what will you do? Can you guess? Patient is having perfect MRI. Huh? Yeah, okay. But what will you do with the patient? What is the treatment? Should we give steroids still? I think I would give steroids. But would I give IVMP? Maybe oral? Look at this. Note. never use oral prednisone as a primary treatment because of increased risk of recurrence. So what is good? What is better than oral? IVMP is better than oral. What is better than only IVMP? IVMP and oral. Interferon beta 1B, and glatiramer acetate are also shown to reduce probability of progressive sequence in high-risk patients. And that is to be given by neurologist. With a negative MRI, the risk of MS is low. %25% at 15 years. With a negative MRI, the risk of MS is low. Okay. 25% at 15 years. Oh, so even if it is a negative MRI, it's not 0% chance. There is 25% chance. There are two lesions, there is 75% chance. So every lesion is, no lesion is 25%. One lesion is 50% chance. Two lesions is 75%. Pulse therapy may still be used, but only intravenous. Though may be withheld unless the contralateral eye has pre-existing visual compromise or patients request treatment and understands the risk and benefit. So if the patient is requesting treatment, then only give IVMP, otherwise do not give IVMP. Repeat MRI in 3, 6 and 9 and 12 months. Put the numbers in the machine if you crack this. It's not that difficult. Every 3 months. 4 times in a year. Every quarterly. And every year. Oh my god. So, healthy girl coming to us with optic neuritis with one lesion. We start with IVMP. IVMP.
1 gram
Per
per
day
day
into
for 3 days.
3 days. Then,
Prednisone,
70 mg per day.
yes.
for 11 days. kg per day.
Or 1 mg per kg per day or 17 mg per
For
day.
11 days.
It's okay. Both of you are correcting each other. Either way it's fine.
Taper.
No, into 11 days.
11 days.
Then
Taper.
taper over 4 days with
20
20 mg.
10.
Okay. Then
Ulcer.
if there are 2 lesions, sorry, and give ulcer. And anti-pantop. Okay. What else?
If 2 or more patients, IVMP, prednisone, also neuroophthalmology.
IVMP, prednisolone, tapering, anti-ulcer, and
Neuroophthalmologist.
neuroophthalmologist who is your fingolemoid within 28 days or interferon. With the chance of every lesion is patient is an optic neuritis, is at 25% chance. Patient is having one lesion, 35% added. Patient is having 2 lesions, 25% added. So 25%, 25%, 75%. 3 things. First, optic neuritis is dangerous, then optic neuritis plus 1 lesion, then optic neuritis plus 2 lesions. With a negative MRI, no lesions, only optic neuritis, 25%. Risk is low. But you give IVMP to every patient. Only if the patient is requesting or if the other eye is already compromised, other eye is already gone. Okay, then you give IVMP to hasten the recovery or to save one eye at least. Then you always repeat every 3 months and then
1 year.
in a patient diagnosis of prior MRIs. Okay, now somebody who is already having MS, somebody who has already had optic neuritis many times. Okay. I would do treatment again and again. How many times again? How many times? Am I wrong? Maybe. Observation from what? From to Watson. In a patient with already MS is there, optic observation, then that's it. You get some. He's saying if she's already with your mother, what you can do? He said, observe. Instead of giving her IVMP, what IVMP will do right now? Her life is spoiled. Re-examine the patient approximately 4 to 6 weeks after the presentation and then every 3 to 6 months. Patients at high risk for CDMS, including patients with CNS devaluation or MRI or positive neurologic examination, should be referred to a neurologist or neuro-ophthalmologist for evaluation and management of possible MS. Basically, if patient is already having MS, it's useless. Not much you can do. It's too late. Even if you give IVMP, she might feel okay with her eyes probably, with her body already controlled. So sad. Look at this, just one thing. Observation till she dies. Essentially what he's saying. I don't think we need to get the follow, but every 3 months follow. So where were we? Follow up every 3 months. Let's simplify it. Other things we will not anymore. So now, very quickly we will go over the yellow highlighted points. Fatima, please read the yellow highlighted points only. Neuritis,
Optic
sometimes.
Nueritis symptoms. Loss of vision over hours to days, usually unilateral, 18 to 45 years. Orbital pain with eye movement, loss of color vision, reduced light intensity, other focal neurologic symptoms.
One second, please. It's a little bit faster. So usually unilateral, okay? 18 to 45 years. And usually unilateral, 18 to 45 years. Okay, those are you with me? Yes, yes, come on.
Yes, sir.
Orbital pain with eye movement. Yes.
Loss of color
Either moment.
horizontal.
Superior. Because when you do superior movement, the optic neuritis is in the back. Optic nerve is in the back. That gets kinked. The kinking of the optic nerve with the superior movement, that's the most painful. What else is there?
Reduced intensity,
Reduced light intensity.
other focal neurological symptoms,
What are the weakness, numbness, tingling extremes. Okay. Then
altered perception of moving objects, Wolfrich phenomenon, or a worsening of symptom with exercise or increase in body temperature.
what is Wolfrich phenomenon?
Moving objects. Feel like that object is moving.
What is Wolfrich phenomenon? The root of sign.
Altered sensation of moving object.
What example I gave you guys? Grandfather clock. But it looks like it's coming like the altered sense of depth is gone. Moving objects. Okay, what else is there?
Silent. Exercise vision is decreased during exercise. That is good for.
Whenever you are having exercise, vision gets bad. That's a very good point. Why vision gets bad?
When
During
we
exercise.
lift weight or
Why? No. Is it because blood is not going to the brain? The blood is very certain, not your brain. If you're taking a squat suddenly getting up, you feel lightheaded. That is venous rhythm is decreasing. That's different. This is actually the increased temperature of the brain, of the body, causes the nerves to not get proper impulse supply. That is what phenomenon. What signs can you see?
Related apparent pupillary defect.
Yeah.
Decreased color vision.
That is very, very important. Then,
Decreased color vision.
obviously, which color you will have issues with? What is it?
Blue was books.
Gabi.
Gabi.
Gabi is what?
Glaucoma.
Glaucoma is blue yellow. Optic Nueritis is red and green. Central and arcuate field defects, maybe near the optic nerve, which we will have some defect with that.
Same. Other signs will be
So this can will be there, only one third. Why only one third? Why not every patient is having that?
Maybe it is retrograde. Behind
Because
the
it might be retrograde.
optic neuritis is more common in adults.
Papillitis?
Yes, in children.
No, that's interesting. Why? In children, the side of the eyeball is very small. So the optic nerve is also very small. Immediately when the optic nerve is inflamed, they will definitely have retina. Whereas in an adult, the optic nerve is quite big. You can have neuritis in many different parts of the optic nerve. So papillitis in children is a good point. Retrobulbar optic neuritis is more common in adults.
Differential diagnosis: ischemic optic neuropathy, visual loss, may progress over 4 weeks, no pain.
Ischemic optic neuropathy, visual loss. This is a differential diagnosis. What else can look like this? If there is ischemic optic neuropathy, what is the example for ischemic optic neuropathy? AIO1, PIO1, AAIO1, NAIO1, these are all ischemic optic neuropathy. Right? So anything where the blood is not going to this is ischemic optic neuropathy. They will cause sudden deep vision like that. But
It has
patients tends to be
neuritis.
in progress over 4 weeks and pain will not be there.
Immediate motility, but in optic neuritis there will be pain.
95% pain people will have pain in optic neuritis. That is very important. Decrease of vision with pain means immediately your brain should go to optic neuritis. Decrease of vision without pain means ischemic optic neuropathy. Patients tend to be older, 40 to 60 years old. What is this disease? What is that disease? Patient tends to be older. GCA. Genital arthritis will have AAIO1.
This is very discussed.
Yes, that is very, we have discussed that. What is the age of onset for optic neuritis? Acute papilledema.
Bilateral disc edema.
If disc edema is there, you should always think of papilledema. But
Here it would be bilateral.
that is why you should not think of this thing.
And also color vision will be normal.
Collision normally papilledema. Anything else of importance there? Nothing. Then livers.
Intracranial.
Mitochondrial.
What was important about liver?
Mitochondrial.
So,
Which was not given to the child during labor.
Only seen in men and from
is
other.
it in men?
Yeah.
Why? Why only seen in men?
It is not given from other
That's okay. But why can it only be only seen in men?
Just for this thing environment.
No, it doesn't always, see, as far as I remember, it is same both. But it can come only from,
Mother.
can only be inherited from the mother. It can go to the daughter or the. So any mitochondrial inheritance related disorder is there. It can
But
always
if father is dominant, why?
the extreme recessive. That is sex-linked disorders. Autosomal disorders will make it gender preponderance of that. But if you're talking about mitochondrial inheritance, that's a different story. Three different things are there. Don't get confused. What other things are there about rapid labor hereditary optic neuropathy? Age of onset was there?
Yes, second and third.
Second, so 20 to 30 years. So even though it is hereditary, it is becoming big by the time the patient is 20 to 30 years. So it is similar to optic neuritis, but there is no pain in the optical motility. Toxic or metabolic optic neuropathy? Who will have this?
Alcohol and malnutrition.
Alcohol and tobacco and B12 deficiency people will have. Toxic or nutritional amblyopia. Then etiology. Idiopathic means it can be due to any cause. Then what is the second most important cause or the most important cause? What is more common? What is the more common cause? Idiopathic is more common. Then you have MS. It can look like the initial manifestation of MS. Why MS initially targets the optic nerve, nobody knows. But it does target the optic nerve initially. Okay, let's say you have optic neuritis, you should immediately be afraid of MS. What else is there?
Viral infection, vaccination,
Childhood infections like MMR,
chicken.
measles, chickenpox, mumps. Did anybody have anything here?
Chickenpox.
Chickenpox. I had chickenpox and mumps. I had measles so far. Other viral infections. Granulomatosis inflammation is tuberculosis. So when the body is not able to inflame properly or undergo inflammation properly, you might undergo or you might see this thing. So workup.
MRI of my brain.
MRI orbit brain, where you are supposed to see what?
If one patient, if one white patient is present in MRI,
Perimetrical white lesions or in the cortex, there might be some white lesions. If you see one white lesion, it means it is 50% chance. Two white lesions means it is 70% chance. To get MS at 15 years. History, determine the patient's age and rapidity of onset. Pain with eye movement is a very, very important thing. Then you perform pupil assessment, perform by the vision, perform vision field, and you perform a directed retinal examination. What is the chance of seeing something in directed retinal examination?
Maybe it can be normal.
It will be normal. Most of the time. Very, very rarely it will have papillitis. Whereas if it's a child which is having papillitis, then you might see papillitis quite easily. Okay, because their eye is very small. Check blood pressure. Why? Check blood pressure. Blood pressure is high. These patients can have ischemic optic neuropathy related this and that. High blood pressure can also cause atherosclerotic plaques. And then immediately causes ischemic optic neuritis. So if you are having high blood pressure, there is a chance that this the reduced vision is not due to optic neuritis, rather due to BP, ischemic disease. That also correlated with the patient's age as well, are more likely to have ischemic. Young patients with blood pressure normal, most of these optic neuritis. Vision field test, you will have this blind spot, you will have central and centrocecal field effects, arcuate field effects. Then you are supposed to do testing. What testing? Which one?
CBC for
CBC for
WBC.
For syphilis,
syphilis is what? RPR,
FTA,
FTA, ABS, line titer, ESR for ECA, chest X-ray for sarcoidosis. What do we see? We see hilar lymph nodes, hilar lymphadenitis. The lymph nodes in the hilum of the lung is having inflammation, proliferation. Then treatment. What treatment? If there is no prior optic neuritis, you're still supposed to do an MRI. In the MRI, you're finding
1 month.
one lesion. Then
Maybe 1 gram
per day for 3 days.
ACMP,
1 gram per day for 3 days.
I gave you 1 gram per day for 3 days. Yes. Then
This on
70
70 mg
per day
into
for 11 days.
11 days. Then
paper
how do you prepare paper
10.
in 4 days? It's very rapid tapering. I should think it is actually 1 week. Then you give anti-ulcer medication that. Then what else is there? What does ONTT tell you?
I with oral steroids.
Iotros oral steroid is the best. 2.
More than
To reduce the initial progression of clinically definite multiple sclerosis. Does it improve vision acuity? It just recovers it to a good state, gives good repairing, but there is never perfect visual acuity after that. Till the patient is the same. Then MRI is showing 2 or more lesions. Then you are supposed to still give IAMP and then send the patient to
Neuroophthalmologist.
Ophthalmology, where he will be given interferon and fingolimab within 28 days. If there are 2 lesions, then what is the chance of risk of this thing? 70%. 1 lesion,
50.
no lesions.
25.
No MRI issues. No.
One MRI 25%.
Not no MRI observation. MRI, everything is dangerous. MS is there. Negative MRI MS is low, then still give IVMP only in patients who have
Patient is waiting.
one eye not bleeding. Patient is insisting.
Insisting.
Patient is bleeding everywhere. Whatever you say, the patient is saying. The patient is requesting. You are not bleeding, still the patient is requesting. Then contralateral eye is completely compromised. What else?
For 3 months. Then 1 year.
In a patient with a diagnosis of prior MS or optic neuritis,